Duna madam? Yeah, go.
Very good evening, sir, and very good evening, ma'am.
Good evening, all. This is Chandra Mohan, Ortho and Sports Physiotherapist from EXRX India. A warm welcome to all the viewers of Fitness and Rehab India YouTube channel and registered participants from various countries. On behalf of Indian physiotherapists, I welcome the physiotherapists from 17 countries, which are registered participants from Egypt, Kuwait, Pakistan, Nigeria, Sri Lanka, Lebanon, Qatar, Nepal, UK, Malaysia, UAE, Bangladesh, USA, Philippines, Uganda, Saudi Arabia, Cameroon. I thank everyone who took time to register for this webinar. And I welcome today's guest, Dr. Annie Thomas, PT, PhD, senior physiotherapist from Bangalore, who suggested us to reach our resource person. Also, she is our resource person for the low back pain series and cranial nerve webinar series. And I request her to give a small talk later. I welcome our resource person who is a member in APTA. Also,
Chandramohan, sir, you there? Yeah, Annie, ma'am, can you hear him?
Yes, I can hear. But sir is not, now I cannot hear Chandramohan.
Yeah, his video also got stuck, but it's okay. I'll be welcoming Sinju Thomas, sir, on behalf of EXRX India. He's a physiotherapist from USA, New York. Sir, we welcome you and request you to start the screen sharing.
Sure.
Yes, sir, your screen is visible.
Hello.
You can kindly start the session.
Sure. Thank you.
Hello.
Hello. Hello, Chandramohan.
Yes. Yeah. I was disconnected. Sorry for that. At the end of this session, there is a client who underwent a spine surgery, and there will be a case discussion. And I request our registered participants to give your registered number and name in our comment section. Before I request our resource person to start the session, I request Annie Thomas to give a few words regarding about Sinju Thomas.
Yeah, good evening. Good evening, Sinju. A warm welcome to EXRS team and hearty congratulations for your presentations today. Sinju's topic is very peculiar and it will be very useful for the community, especially the present things regarding the documentation and clarity in diagnosis and intervention. So I know Sinju from long time. I know he is capable of helping you out in doing this triaging, especially in spine conditions. Already we have had a trial with a kind of patient, kind of a demo patient, and we felt it was very useful and planning for a even for a project with this. So each and everything regarding what he says, it's very important. You have to be carefully listening. Don't even miss a single sentence what he's telling, because the steps which he is describing and the things what is what is all about this triaging system he'll be explaining. And it's very good if you clearly go through whatever he says, then we'll understand whatever day-to-day experience we have with the low back pain is literally they have put up in a nice flow chart kind of. It's not a flow chart, it's a kind of coming to a conclusion. So it's and the last summary will be very beautiful. So please listen to it. It's very worthy. And I'm wishing you, Sinju, all the best, and EXRS team for reaching out all the world is covered, I feel. All the best to even Chandramohan, Duna, and Rupesh. And Sinju, you can start, and I know everybody will be eagerly waiting for your class. All the best. Thank you.
Thank you. Thank you, Dr. Annie Thomas. Thank you. That was so nice of you. That was a good interaction. Thank you. Welcome everyone. Thank you for taking time to learn about a revolutionary change taking place in spine care. My name is Sinju Thomas. I'm a primary spine practitioner and doctor of physical therapy. Today's objective is to introduce you to the current happening in digital health, specifically in spine care. How AI is emerging as a powerful resource in health care. A brief introduction to the machine learning and how it is going to change the way we diagnose. So, clinical decision support system for spine diagnosis and triage. That's our topic of discussion. Let's get started. This might be a lot of new terminologies for some of you, at least some of you, but it will keep you abreast on the technological advances in medical field, which is bound to take over irrespective of all odds. So today's presentation will be exploring clinical decision support system, spine diagnosis, and spine triage. What is actually clinical decision support system? Clinical decision support system can be defined as any electronic or non-electronic active knowledge system, specifically designed to aid in clinical decision making, in which the parameters of individual patient health can be intellectually filtered to generate patient-specific evaluation and assessment, which serve as recommendation to clinicians during treatment, thereby enhancing patient care. I'm sorry, there is a lot of words, technical words, but that is the definition of a clinical decision support system. So it can be an electronic or a non-electronic active knowledge system. And it is designed to bring forth a clinical decision. What's the input? The input is the patient health information. What we do, the tool intellectually filter the information which was put into the tool and generate a very patient-specific evaluation and assessment. And that would be served to the clinician so that they will be able to perform a more informed clinical evaluation. So it's not designed to replace the clinician, but to empower the clinician in the decision-making process. Clinical CDSS is undoubtedly the much needed replacement for traditional healthcare delivery, which is solely based on medical knowledge and experience. So clinical decision support system is a subsidiary of artificial intelligence. So let's start with artificial intelligence. So artificial intelligence or AI is in healthcare is designed to mimic or emulate or improve human decision making. There are two types artificial intelligence. The one is the rule-based expert system. And the other one is machine learning system. So let's explore what is this rule-based expert system. So rule-based expert system are designed to replicate the interpretation and decision making of a subject matter expert. So there are written rules, so the tool perform and follow the rules in order to make a more informed or more accurate, more precise diagnosis or a decision based on whatever information you are putting in. So as long as you're putting in a factual information, whatever the rule is written, the tool is going to derive a more accurate decision or more elaborate or more detailed information versus our traditional subjective recall or a biased or knowledge biased information. The second part is the machine learning. So machine learning systems are used to design and train softwares algorithms to learn from and act on data. So machine learning is, we know that, whenever we Google something and then we start getting that search feed, right? That is a machine learning model. So it is based on the data, like, what you are searching, or whatever is stored in the system, and it is deriving a pattern from the data that is gathering. Algorithm is one of the most top fancy words in digital world after data. So data and algorithm is you go everywhere, like, in digital health world, those are the two fancy words. So what is an algorithm? An algorithm is any method for solving a problem or achieving a specific goal. It requires any number of inputs, including none, and can have one or more output. There are two types of algorithms. One is a locked algorithm and an adaptive algorithm. So software developers use machine learning to create an algorithm that is locked so that its function does not change. So that is, again, the rule-based. So you have a set rules, so the algorithm follows whatever is in the rule. The adaptive one is it changes based on the data that is gathering. So there is more erroneous data than the information coming out from it's a big goal, like, garbage in, garbage out. That is about locked algorithm and adaptive algorithm. Then this is just a small flow chart to show, like, the significance of data. Whether in the medical field, the so-called data is mere raw material for the real work to commence. There is a lot of hype about data, but this so-called data needs to be organized into information that is processed to make it knowledge, refined to bring insight, to analyze the wisdom underlined, and to make this happen, clinical engineers with a high innovative mindsets are crucial. Without them, the data is just a pile of unfiltered files. So we all talk about what's the data, or especially when it comes to a medical world, each data that is there is a subject, is a clinician's perspective. Like, it can be biased based on his knowledge level, his expertise. The information bias means, like, whatever cases that on a day-to-day basis the clinicians see. Then availability bias, information. So there are different varieties of bias involved in clinical decision making. But what is happening with the clinical decision support system, especially in a rule-based algorithm, as long as the rule is that the tool is going to follow the rule. So interpretation of clinical data to classify patients in a timely manner is very crucial. Crucial for cost saving, efficacy, and optimal and in providing optimal care. So early detection of the underlying pathology aid in effective management of any condition and prevents spine pathology from getting worse. Time of intervention is crucial, as overlapping of symptoms occurs in an effort of body's natural healing and complicates identification of structures at fault, resulting in misdiagnosis and ill treatment. This commonly happens. What happens is, like, when you get hurt, you go to a doctor, get some pain reliever, anti-inflammatory and pain relieving medication, and then you keep going 2 weeks, 1 month, 2 months. So after the 7 days, the effect of anti-inflammatory is going to wean off, because there is no more inflammatory process happening. So now the body is in a healing or a repairing process, or a proliferative phase or remodeling phase. That is the time that you should be slowly introducing movement. So most of the time what happened is, in our field, by the time the patient comes, it's the patient is already in a subacute phase, or even maybe in a chronic stage, like, so it's very, very important, the time of intervention, especially when it comes to physical therapy. So that is a brief introduction to the clinical decision support system, but we'll be going in deep later on. So let's go to the next one. That is the spine diagnosis. A diagnosis is defined as a mapping from a patient's data, normal or abnormal history, physical examination, and lab data into a nosology of disease state. So, you gather all the information from the patient and then you compare with your knowledge, your knowledge or your medical knowledge, your expertise, your experience, and then you create or generate a differential diagnosis. So why is medical diagnosis is hard? It is quite hard. It's not as easy as we think. Why? In spine care, especially when it comes to spine care, patients hold back on pertinent information that they perceive as unimportant or irrelevant. Then high cost of acquiring information, whether that be the cost of the test or the time it takes for further talk to the patient. Given that a typical medical provider visit takes lasts only 15 minutes, that is I'm stretching it out, actually 15 minutes, typically it's like 8 minutes, and out of that 8 minutes the undivided attention the patient gets is roughly 3 minutes. Then reliance of regency and availability bias due to the sheer number of diseases that are possible and the need to quickly arrive at a diagnosis. So within that 8 minutes, 15 minutes to 8 minutes to 3 minute time, the clinician has to make a diagnosis. That is it's technically impossible. You have to listen to the patient, and then you have to do the examination. And then you have to move. It is impossible to make. So most of the time, what happens? The diagnosis that the patient get or the clinician generates is it's a biased diagnosis. Lack of appropriate diagnostic tool to gather complete information about the patient. For certain diseases such as mental health, chronic fatigue, or even in spine care, spine care especially, there is no how can I put this? There is no reliable objective finding other than an imaging study, and we know what happens with the imaging. You can't trust an imaging to make a diagnosis. Imaging is to rule out red flags, but when it comes to a diagnosis, you really can't rely on an imaging. It's just like you're buying a car looking at the pictures, or buying a house looking at the pictures. The imaging is to guide the clinician to rule out any red flags, or if the patient is getting into the next phase of care where there is a surgical approach is needed. Looking at the X-ray and making diagnosis and treating the patient is unethical and illegal, I would say. So diagnosis is an evolving task that is temporal in nature and is a complete information game. There's a lot involved in a real real history taking. Like when a patient comes to the clinician and doing a history take, it's a lot of information game. You need to know what is the right question you should be asking, and you need to know when to interrupt the patient. The study says that on an average, patient get interrupted every 18 seconds. If you watch some of the videos, every 18 seconds the patient get interrupted. So the patient is trying to convey their agony or exaggerate their symptoms in order to get the attention of the doctor and the I would say clinician. So the clinician is already deriving their own diagnosis and their own take on it. So researchers unequivocally states that 75 to 83% of outpatient diagnosis can be derived from a skillfully performed patient interview. That is huge. 75 to 83% of outpatient diagnosis obtaining from a patient interview, that is huge. But the problem, as I mentioned before, it's a complete cognitive process. The human brain is cognitively limited to process not more than 5 to 9 facts at any given time. That I'm talking about an expert clinician. So an expert clinician considered 5 to 9 facts to make a decision. So when a patient, a 35-year-old comes with a back pain, with radiating pain to their thigh, a sudden onset invariably goes with sciatica. That's how I used to practice. What happens with the clinical decision support system is they are designed to overcome such cognitive deficiencies to make informed clinical decision in spine care. We have more facts. We are not just relying on 5 or 9 facts to make our exclusive decision. We have more facts. We have hundreds of facts, and we compare those facts with what is there in the knowledge repository. So let's see key players. Who are the key players involved in spine care? Patients, clinicians, telehealth providers, and of course the insurance companies when it comes to Western world, and even in India or developing countries, the insurance companies are budding very fast, which is a good thing. So these players have a long list of concerns. Each one, they have their own concerns when it comes to spine care. When it comes to patients, the lack of accessibility to expert level evaluation and care is a global concern. Not everybody can go to the city and go to visit an expert clinician to get the best care, best possible care. And they often feel their complaints are not addressed effectively. They feel patients often get overwhelmed with differences in clinical rationale between treating disciplinaries. You go to a primary care, a general practitioner versus an ortho, versus a neuro, versus a physical therapist or a chiropractor or an osteopath. You get a different explanation of their condition. And so, patients are frustrated. Often are financially overburdened with the investigation and diagnostic procedures. Then what are the clinician concerns? Clinicians seeks to be the best expert at care for the cases they encounter. However, they are often pulled into the current failing healthcare system. They don't have enough time to evaluate, do a thorough evaluation of the patient. So they have to make quick decisions. They are pressured to rationalize the diagnosis against web-based patient interpretation. Most of the time with the patient Google or do WebMD, and they have an idea about what's going on, and the patient would be trying to convey that to the to the clinician. We all go through this, they are over. The clinicians are over. Most of the time they are forced to do inappropriate investigations under patient compulsion. The patient always want to know, let's do an MRI and let's see let's see what's going on. That is that's not going to take us anywhere. Clinicians often do it because they don't want to make the patient feel bad. Or they don't medical liability. If there is something going wrong, which is less than 2% of any given case, those sinister pathologies. So in order to find those less than 2% cases, that we send patients for MRI or other imagings. Time constraints, documentation hassle, and not to forget the productivity demands are burden, resulting in clinician burnout. It's a new phenomenon. There are a lot of doctors, doctors suiciding, or they're killing themselves. It's too much, especially with the COVID. So let's move on to the digital health platforms dilemma. The emerging health fad of telehealth, a boon during this unprecedented time, comes with its limitation, especially in spine care. With high limitation on any kind of objective measures, digital platforms are hyper vigilant on standalone alerts. Patients' expectation for instant relief further paves for low value investigations and inappropriate care pathways. Then the fourth players are the insurance providers concerned. The insurance providers work to minimize cost, putting strict measures to curtail low value care. For a variety of reasons, the demand for treatment is increasing, which will exacerbate the problem and challenges described. if we stay on the current trajectory, we can only expect inefficient and poor value practices to proliferate. So let's see what the current spine care landscape look like. The US, US spent $135.5 billion in 2016, that is more than 6 years ago, for the neck and back. That does not include spine. So the money, that's the musculoskeletal field is the most expensive medical field over cardiology or endocrine. It's the most expensive field in medical sector because there is because of all the reasons that I have mentioned before. Then inappropriate imaging proves to be a low value clinical commodity with a heavy price tag. Definitely a shocking numbers. I know there is a lot of shocking numbers there. I want to bring your attention to this one particular slide. That is a slide showing the deep blue. That is the number of fusion procedures, and the pink color is the number of refusion. So if you look from the year 1996 to 2011, in less than a decade, the rate of refusion has overtaken the number of fusion procedures. You do one fusion, you move on to the next fusion and the next fusion and the next fusion. So that shows where we stand in spine care. Emergence of diagnostic technologies have led to an exponential rise in spine care costs with no overall improvement in health outcome. The graph which is displaying is the money that spending in what do you call for that, for the neck pain, and this one is for low back pain. So on an average, any spine condition, it's $9,000. Any spine condition, a patient seeking care is averaging up to $9,000 US. So that is significant. This graph shows how in which all ways the money is spending. Okay, so let's see the reason behind the failing spine care. In US, a person over 65 years sees a median of 2 primary care doctors and 5 specialists per year. And those with multiple chronic diseases see up to 16 health professionals. Then the rate of increase, it takes almost 20 years for a major scientific finding to achieve geographically widespread adaptation, and links that variation to the inability of physician in practice to stay current. Variation in the deployment of new medical knowledge result directly in variation in clinical practice. So any invention or any research findings which comes out, or the papers comes out, it takes 20 years it to become a norm, so that a physical therapy student or a clinician, a medical student start practicing that new knowledge. That is significant. Then in 80 to 90% of spine cases, practicing clinicians have legitimate difference on opinion about what is the best, or the differences that what is the best care, and there is a difference that is reflected in wide variation in the actual practice. So a patient going to a orthopedist versus a neurosurgeon, or in between orthopedic doctors also, there is a huge variation in the way they perceive any condition for that matter. I hope I have another slide which is showing the variability rate. There is a study which is showing. And another thing is the expert mind reaches conclusion by breaking a problem into sub problems, pattern matching within each sub problems, and then summarizing results back into a synthetic whole. However, current clinical practice relies increasingly on rate estimation rather than than pattern matching. So we know like how we make a diagnosis. We look at the signs, symptoms, we patternize, and then we make the diagnosis. But the current healthcare scenario, it is just based on the rate. And another factor is the cognitive limitation, which I already discussed before. Disparity in spine care delivery is a non-fact. Though patients' complaint remain the same, the care they receive is highly varied. The patient complaining about their back pain, whether they're complaining to their primary care or the orthopedist, surgeon, or the neurologist versus a physical therapist or a physiotherapist, their complaint stays the same, right? It's how you look at actually, I had a animated picture. Actually, my software team was preparing, and I couldn't insert. I was running short of time, and I couldn't insert. So that is the analogy of 7 blind men seeing an elephant, and how they are interpreting the elephant. They are interpreting as a spear, as a snake, as a broom, as a tree, as a fan. So this is exactly what's going on. We are tied, and unfortunately our eyes we are blinded. So where are we heading? Higher expenses, greater harms, promotion of ineffective care. There where we are right now. So how to overcome this musculoskeletal pandemic? We are halfway through. So clinical decision support system can aid human cognitive deficiencies by integrating various sources of information, providing intelligent access to relevant knowledge, and aiding the process of structuring decisions. Yes, so implementation of a proven clinical decision support system would help, or it's going to standardize the care across the spectrum. So, what are the types of clinical decision support system? There are 2 types. Depending upon who you're talking to, there are different variations. But I know for the sake of this webinar, and to make it very simple, there are 2 types. One is the knowledge-based system, is a system having a knowledge database. Then the other one is the no-knowledge based system, does not have a knowledge store, but uses machine learning and other technique to find patterns in clinical data. Let's go a little in deep. The patient. So what we use as the input for the knowledge-based system, the patient characteristics are matched into the medical knowledge base to deliver a recommendation by a software algorithm. In knowledge-based system, Okay, so what are the components of a clinical decision support system? So it has a knowledge repository that encapsulates the evidence-based medical knowledge that is curated by the expert, by the subject experts. And then there is a rule-based inference engine devised by the expert, which operates on the knowledge repository to generate a differential diagnosis. So the knowledge repository consists of the diseases, then what are the unique findings, and how each variables are interconnected. That is what in the knowledge bank or the knowledge repository. And then it comes to the inference, the role-based inference engine output a ranked differential diagnosis. Like a clinical hypothesis by scoring the disease in the knowledge base as a function to the relationship strength overall in the input finding. In other words, given a set of findings from the patient, the inference engine examines the strength of the relationship those findings have with each disease in knowledge repository. I'm sorry, it's a lengthy sentence, so I'll make it simple. So what it does is we have a knowledge repository. The knowledge repository is like a data bank. It's a knowledge bank, and it has got all the information depending upon each medical condition, each spine conditions. What are the clinical features? What are the findings? What are the things that would be pathology pertaining to that particular condition, and how these variables are interconnected. And then the inference engine use the algorithm to process the information which is fed into the knowledge repository, and then it analyzes, and then it's weighed and scored, and the scored data, that is the differential diagnosis, the clinical hypothesis that is be delivered to the clinician to make their take on it. I hope I'm not confusing anybody here. If ever you have any questions, please make a mental note or write it down so that we can go over this topic again. I mean, we'll revise it. So non-knowledge based system rely on algorithms by applying principles of machine learning model that I already discussed. Those are the things they use for the non-knowledge based clinical decision support system. So we are actually moving to the second part of our topic, that is the spine diagnosis or classification, labeling, or nomenclature. So what is in a name? Remember I told you about the analogy of an elephant and how each clinical field pertain, the blinded clinicians analyzes the elephant and give their interpretation. So that is exactly what is happening in the spine care as well. There are numerous classifications, numerous labeling, nomenclature. It is not actually helping. It is actually making it's more complicated. And not bringing a common ground. So let's discuss about what are the let me go back. We use classification system in spine care. The classification system help to understand the nature of the pain and how the pain affects each patient's life in order to direct treatment. That is what the classification is designed to, versus a pathoanatomical model. The pathoanatomical model is one of those type of classification where we look at a particular structure at fault. So we start treating as a lumbar disc herniation or a facet joint pathology or SI joint pathology versus lumbar strain or a hamstring strain or a OA hip. So those are the pathoanatomical model versus the classification systems. So I'm going to go over some of the prevalent classification system in spine care. And so the classification of functioning, disability, and health, that is the ICF. The other one is the ICD, that's the pathoanatomical based classification. Then there is something called treatment-based classification, that is based on the treatment. We'll be going over this, just briefly. Quebec Task Force classification, that is one of those prevalent time in 1980s, but slowly died down, I would say. Then there is the mechanical diagnosis and therapy, that is known as the McKenzie approach or McKenzie method. Then the movement system impairment by Shirley Sherman and Sullivan's classification. I want to just show a couple of slides which showing how the ICF, that is the WHO's classification, ICF, International Classification of Function, classified low back pain. So these are the classification. So if you look at those nomenclature, acute or subacute back pain with the mobility deficit. So, just to give you an idea, so patient is not complaining about pain per se, the patient is complaining about stiffness. It's very stiff, that's their complaint, or just giving you an idea. So if you come to this slide, acute low back pain with related or referred lower extremity pain. So that is the herniated disc, or a chronic low back pain with radiating pain, spinal stenosis, acute or low back pain with cognitive or affective tendencies, chronic low back pain with related generalized pain. So that is the low back pain classification. That's the ICF for neck. That is four of them: the neck pain with mobility deficit, neck pain with movement coordination impairment, that is the whiplash associated disorders, cervicogenic headache, and radiating pain. So if you look at it, like, see, about 60, not considering the chronicity or the acute, subacute, or chronic nature, if you look at the pathoanatomical model, we are talking about like a 70 plus pathoanatomical model. We are narrowing down or into 5 or 4 classifications, nomenclature. So it's easy to treat once we know what you're treating. And then treatment-based classification, that is also a very efficient classification system, that is depending upon which state or what is their complaint, whether the patient is in a symptom modulation phase or a movement control phase or a functional optimization stage. So symptom modulation is when the patient is acute, the patient is having pain, and so that's the time that you take care of their complaints, their pain complaints. Then the movement control phase is like, the pain comes and goes, but they can function better. So that's a movement control. So depending upon which stage or which classification they belong, the treatment is heavily varied. Then the MDT classification, that is classified into 4 different sub-classifications, and the only problem with the MDT, I'm a huge fan of MDT. The only problem with MDT is we have others in the group, so you can't, there is no, you can't put it in any other category, category, so it belongs to others. So that's one thing. Clinical reasoning in spine care, this was part of my dissertation during my primary spine practitioner program, and I was fortunate to study under the person who devised this clinical reasoning in spine pain, that is CRISP protocol. So in CRISP protocol, there are only 4 categories of spine problems. That is either is a disc problem, disc derangement, purely disc alone, or a joint dysfunction. Joint dysfunction means either a lumbar facet joint or a sacroiliac, or then it's a radiculopathy, so it's a radiating pain, and then the myofascial pain. Okay, so American Physical Therapy Association actually endorsed ICF, even though that is not widely used, but they endorsed, and their guideline is actually incorporated the ICF and ICD. The concept of diagnosis by PT, physical therapists, has been most notably influenced in the recent year by the diagnostic dialogue groups. In 2015, the APTA endorsed the development of diagnostic labels and classification system that reflects and contribute to the physical therapist's ability to properly and effectively manage disorders of movement system. An interesting thing came up in the recent time is the North American Spine Society ordered against the law non-specific back pain. So they are no longer recommending, or they are not going to fund any study which is going to be categorized as a non-specific low back pain. A label cannot be removed from clinical practice without a replacement. So you need a replacement. That is the problem that they are facing now. So this is the one hardcore truth, the truth behind inherited belief that we've been inherited, right? Sophisticated medical testing and medical devices will not lead to specific diagnosis or treatment in 80 to 95% of cases. What are the potential risks? Inappropriate belief about the back and neck pain. Many members of our general public misunderstand that the nature and cause of back and neck pain. They visit the doctor to receive validation of their symptoms through precise diagnosis and specific curative treatment. Yet the majority of low back pain cases cannot be attributed to specific abnormalities. Patients often don't understand that these forms of pain are frequently intermittent, and recurrent, and most of the time the clinician won't be dare enough to say that to the patient. So you get a back pain, you are bound to get recurrent back pain. I'm sorry, but a good clinician, their role and their responsibility is to educate the patient so that the patient know why they are hurting and what they should be doing and what should be doing so that the pain is not going to come back. So if you're looking for, I want to be like 5 years ago, you got a really bad issue, and the whole recovery process is going to change the moment you have a surgery. A fair good amount of patients, they require surgery, yes, but if you have been not diagnosed in the right way, and that is just you're just opening a can of worms, then you're going to have multiple surgeries. But genuine patients, where a surgery is indicated, those people are going to get better as long as they get good education about their spine and empower themselves to take care of their spine and staying active. Instead of learning from pain, we now regard it as an illness in and itself. And then, so once we get a spine pain, we treat spine pain as we are treating a diabetes or a cholesterol or a heart condition. That is not true. Spine-related pathology is a mechanical problem, and once the mechanic is corrected, the patient is going to be see the difference then and there. Or within a couple of visits, not even weeks, they should be seeing at least 50% betterment even when they go to their second week of physical therapy. This I don't want to go over. We are already running short of time, so just it's very self-explanatory. We overtreat the normal aches and pain. We put label to it, and we make it as a pathology, and we start treating our normal aches and pain, and then we end up having a real problem. Overuse of imaging, opioids, and unvalidated surgery and pain interventions are the root cause of the exponential rise in spine care. Then overinflated pricing, industrial monopoly, hospitals are merging, healthcare systems are merging, not to help the patient, but to make more money so that they have more bargaining powers. Inappropriate care pathway, that is a very interesting one. Spine, when it comes to spine pain or a musculoskeletal pain, let's consider spine pain. When a patient having a pain in the spine, it's like the patient getting into a mall or a supermarket, right? They can go anywhere. They can go to a primary care, they can go to their orthopedist, they can go to the neuro, they can go to the chiropractor, they can go to the PT. And where their point of initial contact is very crucial. And what kind of explanation they are getting is very crucial. Inappropriate and ineffective care pathways and ineffective low value cares, So pattern recognition and subgrouping are the key to have an efficient and accurate diagnostic process. Pattern recognition is what differentiates an expert from a novice. The identifying patterns, underlying movement system dysfunction require movement examination expertise. Knowing patterns and using them for condition recognition contribute to efficient use of examination and treatment time. Unless otherwise, it's a movement. Spine pain it's a mobility problem. It's a mechanical problem, and it needs a mechanical treatment. Unless it's an acute one. If it is an acute one, yes, you need some anti-inflammatory to calm the pain down. is for up to 5 to 7 days if the pain is that significant. Other than that, you need mechanical treatment. You need to move the spine. You need an expert need to know. Expert should be guiding you in the right way of moving. So I tell the patients, like, you need to move. So they're saying that I'm already walking, I'm still hurting. Then you're doing some wrong movements. So not everybody get the same exercise. Double knee to chest and standing extensions and prawn push-ups. No, you have to look for a directional preference exercises, and that is not from reading literatures or reading textbooks. You have to go and get trained so that you know what you're doing rather than what you're talking. It leads to efficient examination and treatment time, and you can predict the outcome. That's the beauty of mechanical assessment. Once you start moving the patient, you know what's the prognosis level. Using movement system diagnosis versus pathoanatomical diagnosis. Pathoanatomical diagnosis is not giving you any information other than what structure is involved. What we need is a movement system diagnosis, so that we know which way to move the patient. So we're almost getting there. Coming closer to the end. We're coming to the spine triage. So when to call, when to make the call, right? Like, when a patient walking in and you started treating and you are seeing something unusual, and you need to know your limitation, or what you can't do, or what is your comfort zone, or when the patient need to be referred into the next level of care. So the current problem is there is the lack of efficient triaging, and or the existing poor triage needs immediate attention. When a patient is coming with a systemic when his patient is coming with a somatic manifestation of a systemic problem, you need to do a system evaluation. Simple couple of questions would be able to get information, and if warranted, we can do a more thorough, more detailed system evaluation, and we can make the appropriate referral in a timely manner. Patient presenting physical therapists are considered experts in musculoskeletal assessment, and appear best suited for musculoskeletal specific assessment and triage. I'm very happy with my friends in UK who is working in NHS. I have friends who are working as the first contact practitioner, and they do the triage and they make the call. It's a privilege, and current data is promising in terms of diagnostic validity, treatment effectiveness, and healthcare providers and patient satisfaction. So what can a clinical decision support system do to bring order into current spine care chaos? For the patient, it more detailed information, triage source, comprehension and validation of symptoms, optimize care. For clinician and healthcare system, clinicians are very sensitive to any change in their workflow. And that's why the clinical decision support system can integrate at the point of care and retains the clinicians' decision-making privileges. It is an ideal platform for patient-centric, more precisely, I would say patient-specific care delivery. Studies have, this is the one I was talking about. The studies have shown over 69% disagreement among spine surgeons on how they view recurrent lumbar disc herniation, and 75% variation with lower back treatment in general. Variation in deployment of new medical knowledge directly lead to variation in clinical practice. As I mentioned before, the clinical decision support system can incorporate guidelines or criterion or rule-based treatment into clinical practice, which would effectively reduce treatment variation. And it's an indisputable constituent in telehealth medicine, and it's an answer. A clinical decision support system makes a much weighted concept of shared decision making a true reality. So how will clinical decision support system revolutionize spine care? Implements evidence into practice, brings uniformity in care delivery, establish a strong positive effect on the outcome for pain relief, reduce medication use, improve function, shorter length of treatment, and bring order, bring order to in the healthcare spine care delivery by efficient coordination and communication between all parties involved. So what are the financial aspect? Shortened treatment times with fewer sessions, less than unplanned care, significantly reduce the opioid prescription, lesser administrative overhead. Promote efficient clinician skill time. So the patient, since if the clinical decision support system is a patient-facing clinical decision support system, the patient can put in their information even before their in-person visit. So that way the doctor already, the clinician already know what is going on with the patient, so that they can make they can make their evaluation and examination more skillfully and more effectively. And 60% of imaging is unnecessary. The early you have an imaging, you end up having unnecessary surgeries. So it helps in decreasing unnecessary surgeries. So towards ending, we are reaching to the end of our slide. So clinical decision support system is the need of the hour for the current failing spine care worldwide. Spine experts can't be everywhere, and that's why we need a validated clinical decision support system. So every patient, no matter where in the world, receives expert level spine care. Thank you. Hello.
Yes, sir.
Yes.
Chandramohan sir, you there?
Yes, madam. You muted me actually.
No, I was
Yes,
trying to unmute.
yeah, okay, that's fine. Thank you so much, Sinju Thomas, for a wonderful session. First thing I wanted to tell you, mostly 90% of the messages are the strongest message for the budding therapist. So from here, they have to take a lot of things, especially the ICF classification.
Yes.
When I was calling one of my friend in US, his name is Chenny Bolan. In 2015, I called him and said I wanted to know more about ICF classification. So immediately he replied that in India you are not practicing, so don't even think about now. It will come later. So it was his answer, but he was right at that moment, because now ICF classification is included in the few of our universities syllabus also. So good. They are taking, though they have an introduction part earlier, now they are giving the classification, that numbers also, to bring out the proper diagnosis. So it will be even everywhere. And also there was a strong point that it takes 20 years to change the practice. So even if you
that is, I'm sorry, like I may break a lot of heart, but that's why we end up doing ultrasound and interferential therapy. Unfortunately, yes, yeah.
Yeah, I also tell this point to my friends also, and to a few of budding therapists, that it is not easy to change a patient minds, because for past 30 years we gave them IFT, ultrasound, SWT, and it is not easy to change their mentality towards the exercise and manual techniques, hands-on techniques. So it will be difficult because we already gave full of IFT and ultrasound only.
Yes.
So it may take another 10 years or 20 years because patients and this generation patients learn about exercises and the importance of hands-on techniques and all those things. Maybe after 15 years or 20 years, it will be a clear change. So even
No,
though,
don't say. I'm sorry to say. I'm sorry to interrupt, Dr. Chandramohan, but I don't want that to wait for another 10 to 15. I want those people, those students who have concern, who raise the concern. I want them to start reading about what is the efficacy of modalities in general. And when you read research articles, you have to look. First thing you have to look who is funding those researchers. If the researchers are funded by the modality, the manufacturers, you can't rely on those studies. So if there is no vested interest, then you have to follow whatever is the guidelines saying. But when especially when it comes to spine care, we can't rely too much on the research because the way we classify patient is not proper. A lot of factors involved, but things are going to change with the emergence of technology. Things are going to change. If we are not grouping the patient in the right format, how can you determine whether this particular intervention was effective or not? If you put an SI joint patient along with a facet joint patient, problem patient, and you give an intervention, it's impossible. We have to take with a pinch of salt, but start asking questions, challenge your instructors, and get challenged. And that's how the change happens. And please don't wait for another 10 or 15 years for getting rid of modality-based treatment in general. I would say I am going to get a lot of kickbacks, but that's a take.
no, I agree with your point, but we need entire change of our education system to bring the sudden changes, so that it is not possible in India.
Absolutely, I agree.
Yeah. So it takes a lot of courage for them to bring all those changes. So also you hit that industrial monopoly. It also plays an important role that, okay, those who are providing insurance and just imagine that a good physiotherapist gives a good hands-on techniques and whatever, and he prevents the surgery. You just imagine what the insurance company can do. Okay, it's a loss for them. Some industrial a lot. And you gave a strong message that 60% of imaging and 60% of the images, which leads to unnecessary imaging, leads to unnecessary surgeries. Even I have treated failed back syndrome surgeries, failed back surgeries. Yeah, only after opening the patient's body, then the doctor realizes that why did I open it? And they say that hereafter only physiotherapy will help you, because already the surgery has been done. If they refer at the first point, or if the patient, or we brought a lot of awareness for the public, so the patient comes to us directly, we could have prevented the surgery. For that, physiotherapists must know a lot of inputs also regarding the condition. It's just back pain itself is a vast topic, and you have put in four simple categories that manner, in a crispy way, and the name itself is a crisp clinical reasoning in a spine pain, that disc degeneration, joint dysfunction, radiculopathy, muscle pain, and all those. We put all those things in a simple format, and when we get the simplest format, unless until we study deeper, we understand deeper, we won't reach those simpler formats. Otherwise, we will think that this may be that, this may be this, like that. We will have a vast directions. So we cannot collect it together and we see it through the right way. So we must need a proper knowledge instead of fighting for some fancy terminologies in front of our name. We should have a deeper knowledge to fight that we are far better than surgeons to prevent. Not in all cases.
Not in all cases. I want to give. We have wonderful surgeons who saved people's life. So we can't generalize everybody. So when surgery is warranted, yes, definitely. But yes, we have to have a triage system where we have to determine whether it's true. While I was talking and reading, even a Cauda-Equina syndrome patient, if the time period, a window of 48 hours, they won't do a surgery because there is no point. The damage is already done. For us, it's a big red flag. Then we won't even touch the patient. I want to make a small correction while I was talking about the modality-based treatment. There are newer modalities like laser and shockwave diathermy or some I haven't explored that area, but I'm getting good reviews about it. So I'm not stating, or I was talking about shortwave diathermy or ultrasound.
That's what I can do. The next point regarding the electrotherapy modalities. We should know where exactly it works, how regeneration happens with the help of electromodalities. We should know that, then only we can just simply
exactly. You said it right. Yeah, you need to know what stage the patient is in. So whether the patient is in an inflammatory phase, acute inflammatory phase, or in a repairing stage, or a proliferative or a remodeling phase. If they are in the remodeling phase, you doing ultrasound is not going to take, and the patient will think that the ultrasound that we are giving is what making them getting better. So that is not true. The newer philosophy is less is more. So the lesser you do to the patient and making the patient do more, the recovery is faster. And a lot of things is fear avoidance. The patient is fearful, and as clinicians, we can't. When the patient, we need to make them understand that not all hurt is harm. They're going to go to, when you have been exercise for the last 2 years 2 months to 2 years, and now you're being on a treadmill for 10 minutes, 15 minutes, or you started doing stretching, or you started doing weight training or something, you're going to have pain. So you need to know what kind of pain or how they are narrating their symptoms or whatever, or their feelings, I would say. So if you're just talking about a soreness, you have an explanation. Yes, you just finished a workout, you're going to expect it to have a soreness which is going to last for the next 24 hours. But if the soreness is going to last for any longer than 24 hours, that means you pushed a little too hard. So next time, bring it down a little bit. So oftentimes when the patient say, it hurts, you need to go, or what kind of hurt you're talking about? Is that a stretch pain or a pinching pain or a sharp pain? So if the patient is complaining about a feeling which brought them to us, okay, so they came to us because of that feeling or because of that complaint, because of that pain, then yes, you don't want to reproduce their symptoms. If you are reproducing their symptoms, then you are not addressing that, with an exception in an adherent nerve root problem, or an entrapment problem, or a dysfunction syndrome where there is already an adaptive changes happened, and now the patient is complaining about the pain because the undue stretch in the tissue.
And also, I like the message you have given that all the exercise doesn't suit for all the patients. And recently, we all can see that physiotherapists posting exercise for back pain. So it was social media. So it gives a wrong conclusion that if you do this, you can get rid of back pain. So it was a very good message for the budding therapists, not only budding therapists, even for the physiotherapists who post video of exercises for back pain, they should think about it because it may be harmful for the clients or public. So they should avoid doing it. Otherwise, they should give exact reasoning behind it. If you have such kind of back pain, then you do it. Blindly, they should not do it. You gave a strongest message for the.
I would like to add one more point to what you just said. That's the biggest mistake that we're doing. Even when I was practicing in India, one thing I always advocate that you can educate people in different forums, in different platforms, but don't list out the exercises for shoulder pain, for back pain, for neck pain. That is a wrong practice. That is actually degrading your profession. Yes, it looks good with your picture on a magazine. Dr. So-and-so is talking or writing, but if you can educate the patient in a nice and simpler way what is going on, but not the treatment. That is like a general medicine practitioner writing about high blood pressure. Okay, when you have a high blood pressure of 170 over 60, this is the medication you should be taking, and he's writing. So we are movement experts, right? We are experts in our field. We are the one who's deciding what kind of movement and what kind of exercise the patient should be doing. And if you start throwing it out or start selling just for your own benefit, just to show your face in the magazine, I think that need to be stopped completely. You should not be doing that because each patient is different. You need to analyze the patient, you need to evaluate the patient, you need to spend time with the patient so that what kind of exercise or what kind of which direction they should be moving, or so it's very, very crucial to identify the direction of preference or the right exercise for the patient. To make it very simple, if you are giving an exercise or a patient is doing an exercise and they're getting the same pain they came to us, then you are doing harm to the patients. You better stop doing that.
Yes. I request our listeners to take home this strongest message that you should be aware of posting exercises in social media. And
absolutely.
I request Duna Madam to post Zoom link in YouTube comment section, and I request our viewers, those who want to discuss, you can join with us. And here we have two more personalities here. I would like to invite Dr. Benil Pillai. While the session is going on, he said, I taught Sinju, and I'm watching Sinju now. So I said, sir, why don't you join? He joined immediately. And sir, I welcome you, sir. Benil Pillai, sir?
Yeah, hi, I can hear you. Thank you so much, Sinju, for a wonderful talk. It's such an elaborate thing.
Thank you so much for joining, sir. You know that how much I value your presence and your advice. One thing that he was my teacher when I was doing my bachelor's program in Mangalore. And I can proudly say that he's my best teacher. And he is the one who taught me one time, which opened a lot of opportunities to me. He told me once when I scored very less in my neurology exam, he told me there are short-term goals and long-term goals, and I took to my heart, and that helped me a lot. Thank you so much.
Absolutely, buddy. Take care.
Thank you. I have sent the photographs, and the client Ashraf is here, who underwent cervical spine injuries. He's here, sir. Would you like to talk to him?
Sure.
Discuss with you. Yes, please, Ashraf. Mr. Ashraf.
Hi. Good evening, everyone.
Hey, Ashraf. How are you? Good evening.
I'm good, sir. Actually, thanks for the very good informative information. Actually, some of the portion I didn't understand because I'm a patient. I'm not a specialist over there. And first of all, I wanted to start thanking Mr. Benil Pillai. He was my therapist over there in Dubai. And thank you, sir. Thank you very much. I never forget your help. Not only you, actually, the whole PT members over there, and Mr. Dr. Karim, of course, definitely. I never forget all you. Okay, Mr. Sinju, sir, actually, it's almost about 43 months now after my surgery. Okay, I'm doing well, but still I have pain in my shoulders and pinching pain in my forearms, fingers, and wrists, both wrists particularly. Okay, and these things are still going on with me. So because of this pandemic, I'm not getting proper sessions over here because I'm from a small town. So I don't know. I'm a bit worried actually. What should I do to prevent this all pain actually?
Dr. Chandramohan actually sent me some pictures just before the webinar. I'm just going through the. It looked like you had a fusion. You have an extensive level of multiple level fusion.
Yes, sir.
So you know, and before the surgery, what was your symptoms?
The symptoms were, it started like weak kind of pain in my back. Okay, it went like almost like 10 to 15 days, and I saw a doctor in Dubai, and they started physiotherapy sessions and medication as well. But the things are getting worse day by day. It started this numbness, in my toes at the beginning. Then it is, increasing like, day by day. And it came up to abdomen, actually, within a span of 1 week or 10 days. So suddenly doctor suggested me to go for a surgery, actually.
Wow.
So then I went to Neurospinal Hospital in Dubai. I met with Dr. Karim, and he has suggested me for a surgery as well. So it happened within a span of 15-20 days only. Even I was not aware actually what kind of surgery they're going to do on me and what I'm going through. I don't know. I didn't have any idea actually. Okay, all went like, within 15-20 days, I went to the, hospital actually.
Yeah. So the way the way you are complaining or narrating your clinical symptoms and what led to the surgery, it definitely warrants a surgery. That's how it sounds like. It's a progressive neurological complaint in a very short span of time. So the surgery was required. How are you feeling after the surgery?
After the surgery, sir, it took almost a month to stand on my own. Actually, I started walking with the help of Mr. Benil Pinlai. After a month of and it took 2 months for me to stand and walk on my own, but of course with some help. Okay, and it's almost like 6 months. By 6 months time, I was able to do all the things. Only the upper limbs actually, especially in my right hand, I had some issues. I couldn't able to write. I couldn't able to hold things. Okay, and motor issues actually, fine motor issues were there. And within the span of like 1.5 years, 2 years, I was able to do everything. But only thing is like, still I can feel some weakness in my right hand. And every morning I was okay, but by the day progresses, like, by evening 4-5, I'll feel pain in my both shoulders and neck, all those things. And my wife actually learned many things from Dr. Pillai and his staff over there, and she's helping me. She's doing some massages and all, which she learned over there, and she's helping me to recover. But still, I have pain.
I see. The thing is, how can I explain this? What kind of job you do?
Actually, I'm a logistic professional. I used to like the symptoms could be like, why I had those issues actually in my area. Mostly the doctors saying like, the fluoride content is more in my area. That could be reason. Actually, my bones became fragile. And after that, I played cricket and professionally some for a long time, like 3-4 years. And then I went to Dubai, where my job is like, I had to sit all the time in front of my system, and I used to drive a lot. And those could be the reasons actually why I got all these complications actually. Okay. And now I'm not doing those things actually. I'm back in India. I'm working for ICICI Prudential. Now I'm a financial advisor for them. So I wanted to take some break, actually. That's why I choose that kind of job where I had less pressure on me, like, so I'm enjoying these days, actually.
Yes, yeah. So if you look at it, like, you are doing a sitting job basically. So,
Okay.
the first and foremost thing, without, like, over the phone, it's really, really hard. The
Of
first
course,
advice is to correct the posture, and
Okay.
then you need to find you go, find an expert in not a doctor. You need to go to a movement specialist, like a physical therapist who is trained to do, like, if you can find any certified McKenzie practitioner, that I would strongly suggest. They can do an evaluation, and they can give you an idea where you stand and what is causing all these symptoms. I would strongly recommend that.
Thank you. Thanks for the advice, sir. I'll do that. I'll do that.
And watch the way, because all these, other than playing cricket, all the other things that you mentioned is a sitting job or bending.
Yes. Yep.
Okay, so watch the, so maybe you have to correct the way you're sitting. Do you sit on the sofa a lot? Do you sit with your legs up?
Yes, I do sometimes. Yeah.
Yeah, those are all precipitating factors.
Okay.
So you need to. It's hard to without, if I know you examined you or something like that, then I would be able to give you a little more information. But you can follow what all things Vinod told you, and along with that, the first and foremost thing is watch the way you are sitting. Make sure you're watching your posture. That is the key thing. If you're not, you can do all kind of surgeries, and you can go and do all kind of treatment, but you're sitting and in a wrong way, and putting strain to the spine and the disc, and creating traction and compression to the nerve. The nerves are very sensitive tissue. You need to follow, you need to see what are the times that you feel pain, what makes your symptoms worse, and then what you were doing that time. Those are you have to find a pattern. So you keep tracking, what are the things that you were doing, what makes your pain bad. So when you have a fall, you always look where you slipped, not where you fell. So you have to look what led to your symptoms. So 10-15 minutes before, what you were doing.
Yes,
So
sir.
one simple question. Let me ask you one simple question. Do you have any pain when you're walking or going somewhere?
No, I don't have any problems, sir.
Okay, so that itself is showing that your problem is not a major problem. So if you if you have a major issue, then you have a problem with walking, you have a problem with doing things, when you're active. So if you look at a pattern, your problem is mainly when you are idle, when you are not doing, or when you're relaxing, watching TV, or getting up from a chair, or taking a break, or something like that. You agree?
Yes, sir. I agree completely.
Okay, so those are the factors. Then you need first and foremost thing, you need to take don't sit on a sofa chair, don't sit on a recliner. Make sure you sit on a straight chair. Watch the posture. You may have you should see, to make it very, very simple. If you have a genuine problem, then you won't be able to love what you like, love what you want to do, playing cricket, or do you play cricket now?
No, I never tried that after surgery, actually, because I cannot hold the bat properly initially. It slips from my hand. Actually, I tried, but I'm playing shuttle nowadays in the morning, especially.
Yeah. So when you play shuttle, does it hurt?
No, I don't have any problem. Only thing is, I couldn't able to hold properly how I used to in the past, actually.
Yeah. So so Ashraf, basically what is happening is, you are making your symptoms bad by sitting in the wrong way and carrying yourself in the wrong way. If it is a genuine problem, then you won't be able to play shuttle, or you won't be able to go for a regular walk, or when you're active. you won't be able to do that. So when you do, if it is a genuine problem, if you do when you do those kind of things, you'll be having pain. If you look at your pattern, when you are sitting idle and when you're relaxing, that's when you are getting the pain.
Yes, yes, I agree that, sir.
Yeah, so what you need is you need to find a good physical therapist locally who is trained in mechanical diagnosis and therapy, that is a McKenzie. And your massage is not going to help you at this stage, because at that time you are immediately after surgery, you need your muscle spasm and tissue healing, then you needed that. But at this stage, I hope your wife is not hearing, she's going to like, she's like, I'm done with massaging you. So what you need is movement, and you need to find the right person who's going to show you the right kind of exercise.
Okay, that's a valuable message for me, sir. Thank you very much for that.
Mr. Ashraf,
I'll do that.
please stay online. Mr. Ashraf,
Sure,
please
sir.
stay online. I
Sure,
request
sir.
Vinil sir also to give suggestions from his side, because
Of course, he know everything about me, actually. He saw me before surgery and he saw me after the surgery, and he helped me in every way, actually. Thank you, sir. I'll wait.
Yeah. Sir, Vinil sir.
Yeah, hi. Hi, Sinju and Ashraf. I just want to update both of you what exactly the scenario was maybe 14 months back. Pre-operatively, Mr. Ashraf had an aggressive cervical myelopathy. If I'm not wrong, it was in 4 levels. And it was attempted to be treated conservatively as much as possible, not only in our hospital, in another hospital as well. But the moment he started to pick up truncal spasm, there was increased tone spasticity. As most of you are aware, if you see what we call as upper motor neuron symptoms coming, then they question mark it for a surgery. And then he started to have a bit of weakness distally, and that was a call which was made by the surgeon, where we were not involved in it at all. So just to give you an idea of what it was pre-operatively. Now, immediate post-operatively, what happened? Because multi-level fusion, what happened is he had a cord ballooning. I don't know if you guys are aware of it, but what happens at times is, when you are completely constricted, the cord is like tight inside the canal. And when you release it, it suddenly just balloons. And that ballooning effect causes a reflexive weakness. If you agree with me, Sinju, so far?
No, not really, actually.
Okay, so what happened post-operatively is he had a spinal cord ballooning, which is like a spasm within the canal, a spasm within the cord itself, which led to weakness on all 4 limbs. So basically, Mr. Ashraf was, for a month, I think nearly a month to 3 weeks, he was bedridden. We needed to get him up. And then the healing started from where he actually got. Anyway, come down the story, I think I saw Mr. Ashraf maybe 2 years back or somewhere close to that. He still has the weakness in his bilateral hands. So that is one of the effects post-surgery on the neural tissue itself. We checked dynamic neural and all those things were fine. There was no real adhesive tissues. Couple of trigger points here and there. But again, the whole thing is mechanical, because he learned to move in a different way post-operative because of so much of weakness. I mean, when we talk weakness, we're not specifically saying just the biceps or a wrist flexors. He's got all the muscles. It was quadriparatic. So from there, a lot of development. So we were completely focusing on exercises, strengthening the key muscles, and post-exercises was the family job was to apply the cream and things, but not entirely passive as massages. So yeah, again, I totally agree. We just need to continue with. I think till the very last minute, the occupational therapist was working so hard with Mr. Ashraf to get hold of his grip, his prehension grips, the movement on the thumb to index. So we did a complete. I think she did quite a good job to actually address that. But yeah, it is still not 5 by 5 if you want to put it. Yeah, I would put it like still at least 20% weakness is still residual. And probably because of that weakness, there's a lot of mechanical imbalance, which he's using other muscles to help, and that causes all that sort of imbalance in the whole muscle tissue buildup and causes the pain and nag. But yeah, just to update you, the neural side is absolutely fine. I checked you all the upper limb and lower limb. He's absolutely fine. Just to add in, just to give you an idea.
Good, very good. That's very informative. Wow.
Thank you, sir. Yes. Also, I appreciate that he also appreciated one among the team member, occupational therapist, and that's good actually. So it's a teamwork. Again, you remember reminding us that it is a teamwork. So we appreciate the occupational therapist who took care of Mr. Ashraf also. And thanks for all the inputs, sir. Vinay Pillai, sir. Thank you so much. And yeah, and we will move on to question and answer session now. And there are no pictures in the session, no spine pictures, no images like that. So maybe we have very less questions due to that, because our physios are most keen into learning some techniques. They need some cracking sounds, and they need some pictures, they need some special tests. They immediately want to learn some techniques. So here nothing is there. Okay, it's full of a knowledge session. So questions are very less, but appreciations are more in the comment section. Okay, even one physiotherapist from Kolkata messaged me that, sir, I missed today's clinic session to attend this session. It is really worth watching, and kindly share the link to as many physiotherapists as possible. So that person also recommending his friends to watch this session. I thank Dr. Fayaz Khan from Kolkata for that. Thanks for your appreciation.
Thank you, Fayaz. Yes,
And,
thank you.
And from Dr. Arun Balasubramaniam, he is former principal and presently working in a General Hospital headquarters, Erode. And he was saying that it's great speech, Dr. Sinju. Very happy to learn a lot. He's having one query. Is there any TBCS specified for all musculoskeletal injuries?
Treatment-based classification for musculoskeletal injuries in general, or?
Okay, he was not specifying it. I request Duna, madam, can you provide a Zoom link to Dr. Arun, sir?
Okay, sir, I'm forwarding.
So there are a lot of appreciations for you. Thank you, sir, for valuable informative session from Balakrishna. Kiran Dayal, very informative session. Ashraf Yasin, she is also a professor. Thank you very much for this wonderful session. And yes, knowledgeful session. Ankit Kumar, thank you all. Marimutu is saying that's a different and apt code for ethics you taught us for our profession, sir. Thank you so much.
Thank you. Thank you. You guys are very generous to me. I thought, I have 97 slides, how I'm going to do this. And if I do anything short, I won't be doing justice to the topic. And it's a time waste for the people who waited for this topic. So, I put a lot of slides in there. So I hope everybody stayed throughout.
Yes, this is really, it shows. You can go through the comment section later. From Ashokan, he was saying that we are very much proud to be a part of this webinar. Thanks a lot for this great opportunity.
Thank you. Yeah.
And yes, many appreciations are there. Duna madam, Arun sir has joined or not?
Any questions? I would actually, when we had the Dr. Chandramohan actually approached me with regard to this webinar, I actually thought I'll just come and sit and we'll be having an interactive session. Then he said actually day before yesterday, 2 days ago, he said there are 658 people registered. I was like, what? So I had no clue about this platform, and I felt so ashamed of myself. So all the slides that you guys saw happened in the last 2 days. So when Dr. Chandramohan sent me Mr. Ashraf's MRIs, I said, I'm so sorry, I'm finishing up the slides. Thank you so much, Ashraf. I forgot to thank him. Yes, yeah. Any questions, please? I would love to.
There are few questions in the chat box. I would like to take till Arun sir is joining.
Sir, Arun sir is in another meeting, perhaps. He's
Okay,
listening to your meeting, but joined in another one too.
Yeah.
Okay, no problem. There is a question from Indra Priyadarshini. Sir, can we use manipulation techniques post-surgically, like decompression in disc prolapse?
Yes, I actually answered that question in the chat box
For
itself.
the viewers' purpose, I read. I saw the
Oh, okay. So I am not technically here to talk about the treatment, but since you asked, I was more on to the diagnosis part. So if you are not diagnosing the condition, then your treatment is going to be in vain. So it's the key is to understand the patient, understand their problem, and then planning their plan the care. You formulating the plan of care. Coming back to the question, can we use manipulation technique? Yes, there is nothing wrong in doing manipulation. The first and foremost thing is who is doing that manipulation and how far away from surgery, and are you doing the manipulation in a graded manner? Did you start with grade 1, grade 2, grade 3, or you're going to the thrust manipulation right away? You don't know where you're going or where you're taking the patient and what to expect. So there are a lot of factors involved in it. Especially it's a post-surgical case. It is just written post-surgical. So I hope it's not a fusion. I am not comfortable personally to do a manipulation on a fusion spine fusion. But if it is a laminectomy or discectomy, I'd be okay as long as the patient has recovered from that surgical procedures.
Yeah, thank you so much. And the next question is from our YouTuber, Dr. Vishnu. Why neck and back pain is not included under spinal problems as per USA? Kindly explain.
Well, you were breaking up, Dr. Chandramohan. Can you say that question one more time, please?
Yes, I will repeat it. Why neck and back pain is not included under spinal problems as per USA norms? Kindly explain.
I don't know from where Arun got that information. There are two spine. Obviously spine includes the cervical, the thoracic, and the lumbar. But as far as the guideline comes, there is no guideline thus far under APTA for the thoracic region. So there is a guideline for neck. And there is a guideline for lower back, but nothing thus far for thoracic region. That's the information I have. Correct me if I'm wrong, please.
Yeah, okay, no issues. And there is another question from Manikandan. Sir, can we add non-specific low back pain in the back pain classification?
Yeah, I think I had a slide. According to North American Spine Society, that's one of the biggest organization in worldwide, especially in US. Their guidelines came out beginning of this year, 2021. They said they took away the non-specific spine pathology. They took away that the category entirely. So there is no longer non-specific, but there is no replacement for it. So how you're going to replace it? So there is a lot in the air. There is a lot of lack of clarity so we need to come. We have to be wise enough to combine the classification system when you evaluate the patient.
Okay, sir. Thank you. And the next question is from Marimuthu. In USA, does they follow biopsychosocial model of physiotherapy?
That is an upcoming thing. Yes, biopsychosocial model of physical therapy. I mean, not just the physical therapy, for spine care especially. It is taking a very good stance, and they are seeing, yes. But you always remember, like just like in India, America is also a big country, and there is a huge variability. Here also there are people who do ultrasound and stick with the very basic treatment. So it depends upon where and who. I strongly feel in our profession is the lack of specialization. Even though we have MBTs and doctoral level in specialized field, but there is no designation that so and so person is certified or specialist in that particular. So we become like a general physical therapist. We treat cerebral palsy, we treat stroke, we treat low back. So there is no we are not specialized. I strongly recommend the current physical therapist and the student physical therapist to pick a topic of interest and start exploring that one and be a specialist in their field of comfort, whichever field they choose. If they're choosing cardiothoracic, just focus on cardiothoracic. Neuro, just be a specialist. You don't want to be a jack of all trades, a mediocre therapist. That's when you become a mediocre therapist. So if you're focusing on orthopedics, focus. You do all the continuing education in orthopedics, and we can go to 101 webinars or conferences, but if you're not changing the way we are practicing, it's waste. We can show in our CV that we attended and not practicing what we learned. That is not the good practice. That you are not going to learn. We stay where we are. We become stronger in our comfort zone. That's the difference between an expert clinician versus experienced clinician, and so there is a huge difference in being an expert clinician versus an experienced. An experienced clinician become experienced in his realm of practice, in his own ways, in his own limited knowledge, and he's experienced in that. What differentiate an expert from the experience is you putting effort in one particular field and working towards it and working hard to get where you want. Be an expert.
Thank you so much for that sound message regarding the expert and the experience. It reminds me of our studies. There was a question, novice versus experience. There was a question for 5 marks or 10 marks in the examination.
So what was the question? That was interesting. What was the question?
Novice. That is freshers and the experience. The freshers.
Yeah. There is a huge. There is. Yeah.
A lot of difference. They go to ICU, they will tell the patient is sleeping, then come back. The experienced physiotherapists go and treat. Like that's the same way here, experience and experts. And I come back to Dr. Arun Balasubramanian's question. Is there any TBCS specified for all musculoskeletal injuries? He's asking generally for all the MSK injuries.
Yes. It is an evolving classification. 2016, actually, they revised. I think there was the first one came out in 2012. That's the first time they came out with the treatment-based classification. But if you can go PubMed, you can type in, it's a free research article. You can find it. And they revised. With made it even narrower, and it's a very that is something that we are working towards. Actually, we want to have a treatment-based classification so that we know what phase the patient in, and we can incorporate treatment and more effectively. So currently in treatment-based classification, there are 3 categories. That is, one is the symptom modulation phase, then movement control, and then functional optimization. So symptom modulation, symptom control phase. Symptom modulation phase is where the patient is in an acute flare-up stage, where the patient can't barely move, walk, and all those. There the pain scale is like a 6 out of 10 or 8 out of 10 or 10 out of 10. And then the movement control is that, they started moving, they can move, they can do things, but there are pain with certain activities, so that's the movement control phase that, treatment changes. So not everybody gets double knee to chest and prawn push-ups and straight leg raises.
Yes, thank you for the answer. And the next question is from Neha. In terms of practice of physiotherapy, which country is good, India or USA? Can we learn more in USA?
You can learn. There are very high quality clinicians in India as well. You can learn wherever you can learn. Google is such a wonderful, but you need to know what source you are reading or what kind of research you are looking into. Whatever you learn, you explore that. And then you ask questions. You question yourself. Question what made them write that. What's the rational? What's the clinical basis behind it? You start asking questions. You find answers, and those answers are the one which leads you go further forward. So yeah, you can be in US and taking not going for any courses or refreshing your knowledge or no, and don't think that it is people go for webinars and conferences and get certifications. It's like a mechanic with a truck versus a mechanic with a toolbox, just a handheld toolbox. You may be having a ton of tools in your truck or your van, but you don't know which one to use at what time. But you may be very handy with a handheld tool box, but you know which tool to use at what time. So that is a lot of experience, as Dr. Chandramohan has mentioned before, and a lot of reading, learning, and spending time. Have a genuine passion to what you do. Be an expert in whichever field you are in. That is a key. Challenge yourself.
Yes, thank you, sir. Thank you so much. No more questions here in YouTube, and I think all the questions are answered in Zoom also. Rupesh, you there? Has Rupesh joined with us, madam?
Yeah, he joined, but audio not connected.
Okay, no issues, madam. And I take this opportunity now to wind
just
up.
one before we wind up. I have one small request. I see that there are a lot of professors and associate professors has joined. I would really I'm looking for a research collaboration. Dr. Annie Thomas is helping me with one. So we want to validate the tool we have, and if you want to know more about the tool, you can go to the website, that is www.therafa. So instead of therapy, instead of Y, it's A, the Rafa, THERAPHA.com. So that's a website, and please try to reach out to me via Twitter or LinkedIn. I'm there in Facebook, but I won't spend time on Facebook. So
even if our participants, those who are going across this webinar, and if they need our number also, I'm happy to help them. And I will give the contact number and details of
I don't recommend giving the contact number. Please don't give the contact number to anybody without asking me.
Mail address.
Don't give the contact number, but you can share my LinkedIn. I think I shared the LinkedIn. You can just search www.linkedin/Sinju.Thomas. It's going to come. Please reach out to me via Twitter or because when you're working with a patient and all of a sudden somebody calls and it's it's very disturbing for the patient.
They will call you like that. They will send you a message. Then only they will talk to you. Don't worry.
I would rather have a social platform. I don't.
It's a way of keeping in touch with our own professionals to clarify our doubts, and yes,
absolutely. Reach out via LinkedIn or Twitter.
And now before winding up, I would like to thank Duna madam for making all the arrangements, especially taking care of the registrations and connecting YouTube, and even teaching Sinju sir for sharing the slides and all those things. And I thank Rupesh, and I thank Mr. Ashraf patiently waiting till the end. And thanks for sharing your story, what
Yes.
you have underwent. And this is the first time we are having such a session also, okay, live case discussion. It's a kind of telephysiotherapy now. So that also we have done in an open platform. Thank you for that, Mr. Ashraf. And I thank Binil Pillai sir to stay with us. There are a lot local time issues, but still he joined with us and he's staying with us. Thank you, Binil Pillai sir. And I thank Dr. Thomas for suggesting me to approach Sinju Thomas. And I thank everyone, all the participants. Even still, there are participants who are watching in our YouTube channel, and a few more are here. Thank you, everyone. Good night. See you all in the next webinar. Bye-bye.
Thank you so much. Thank you. Thank you. Bye.
Good night. Good night, Dona Madam. Bye-bye.
Right, sir. Thank you, sir. Bye-bye.